It's time for AllyCon to resume. Please welcome to the stage our event chair, Dr. Sharon Stein, and our esteemed panelists.
Everybody had some great food, got to have some fabulous conversations, and we are going to shift gears just a little bit over here. I know this morning we talked a lot about new therapies and new things, and we're going to go back to the beginning. One of the things I really wanted people to walk away with was the information you needed to go to your doctor to ask questions and to do things. And some of that is about the information that they gave this morning. But I have this phenomenal panel that I'm going to introduce to you that is going to talk to you about the beginning of the journey and the questions you should ask or could ask, and the opportunities to really kind of own this journey. And that's what we're going to concentrate on just here. So let's get to it. Oh, there we go. See if it's switching there for us. So let me go down the line and introduce you to my amazing panel that have come from all over the country. First, we have Dr. Larissa at Temple. She is a fellow colorectal surgeon and the chief of the Division of Colorectal Surgery at the University of Rochester in Rochester, New York. Next, we have Jenna Scott, who is an amazing person and is also our patient representative on the panel, and she's coming to us from Peachtree Corners, Georgia. Followed by Carly Roop, who's a certified specialist in oncology nutrition and one of the experts in Ask the Expert. So you can find her in the back corner over there during our breaks. And she comes from University of Pennsylvania's Abramson Cancer Center in Philadelphia. We're following that up with Sean Powell, who is also one of our Ask the Experts. Sean is the Director of Social Work and Patient Support Services at Moffitt Cancer Center, so just up the road in Tampa, Florida. Dr. Sarah Hoffe is a head of the GI radiation oncology at Moffitt Cancer Center as well. And we're going to follow that up with Dr. Eric Christenson, who's an assistant professor of oncology at Johns Hopkins University. So let's give them a warm welcome. So you guys, we have a lot to cover in the next 54 minutes, so I'm going to jump right into it, and we have a lot of opinions up here. I will say we're not going to do a Q&A for this, but I am sure that any of these experts would be happy to be stopped in the hallway, to, bring them a coffee and ask them a question at any time. So let's go ahead, and we're going to start off with a newly diagnosed colon cancer. So let's just take a 55-year-old who presents to the clinic with this newly diagnosed sigmoid colon cancer. I'm going to start over here with Dr. Temple. Dr. Temple, when somebody comes in, what are the things they need to know about staging? What is that first step? And how does that how does that proceed in your office, or how do they get to your office, that type of thing?
So patients get to our office in so many different ways. We heard a story this morning of the gastroenterologist going over the results after colonoscopy. Sometimes people come in having had a biopsy, and they come in and the first time they've heard about the diagnosis is when they walk in. So I think it's really important to sort of take a breath. And then really I start by talking about the natural history of colon cancer and sort of talk about what we need to do to make the right decisions for this patient. And so one of the most important things is that we get accurate staging, so we know if this tumor is best served with upfront surgery versus chemotherapy. And so we really have to do proper staging. So for patients with stage 1 through 3 cancer, colon cancer, we now know still that upfront surgery is the preferred option. It may be changing with some of the immunotherapies, but the most important things to me is that they've had a colonoscopy. Ideally, it's complete, but if the sigmoid cancer is causing blockage, then we'll have to deal with that after surgery.
So let me just ask you,
yeah.
and I love to pick up these things, but what does a complete colonoscopy mean?
So a complete colonoscopy is that a gastroenterologist or a colorectal surgeon has observed the entire colon. So the colon is about 6 feet in length, and we like to make sure that the entire colon has been reviewed, because we know that about 5% of the time there's a second large polyp or cancer. So we like to make sure we've had a good evaluation of it. And so when you look at the report, and when the surgeon looks at the report, they're looking to see if they saw the tumor, especially, and if they're able to go all the way around and see what we call the cecum, or where the appendix comes out, or where the small bowel goes in. So that is, to me, a very important part of making sure that we've completely surveyed the colon. After we've done that, we want to understand whether the tumor has spread outside of the colon using a CT scan of the chest, abdomen, and pelvis. We also do a blood test, a CEA, and that's sort of how we begin the staging.
Great. So let me go down. Carly, I'm going to pick on you next.
Okay.
One of the questions I'm asked all the time, and I'm sure you are asked all the time, is the patient comes in, what can I do about my nutrition? What should I start or stop eating, at this time? Like, I just received my diagnosis. What's the advice you give a patient there?
Well, it kind of depends on what they've been through already, any kind of issues that they might be having GI-wise with their, going to the bathroom, or if they've recently had a colectomy, so that 6 feet is now 4 feet, or, just depending on that kind of will sway how I would respond to a question.
So what about the new patient? The patient who comes in who hasn't had any surgery and is not blocked or anything, maybe having some constipation, but should I stop eating processed sugar? Should I stop eating mushrooms? Like, what are the things I need to do?
So for that person, I would encourage them to follow the guidelines of the American Institute of Cancer Research. And that is just that we want to have a pretty plant-forward diet. We want to, which means you would want to include lots of veggies and fruits. Then you would also want whole grains, legumes, lentils, seeds, nuts, herbs, and spices. So that's like what you want primarily your diet. And then you also want to include lean proteins. So lean proteins being from your fish or poultry, then lean meat. And when it comes to, I guess, limiting foods, sure, I think we want to kind of limit how much processed sugars we have. So how many sugars that we get from sodas or sweetened beverages, candies, cakes. Doesn't mean that they can't be in your diet, they just aren't going to be the foundation of your diet, because they're not generally very good for us. They just taste good. And then the other thing that I would say you'd want to kind of cut down on would be processed red meats. So that is bacon, sausage, lunch meat. This is when people start not liking me. Pepperoni, prosciutto, all the things that people really love, those. We want to start making that not an everyday food. We want that maybe try once a week, then try twice a month. Just trying to make it not like a staple. And then alcohol. So I am just not fun. Alcohol's fun. Alcohol tastes great, but it doesn't do anything for us. We've known this all along, but that is something that if we're going through cancer treatment or we're really trying to avoid cancer recurrence, then limiting how much alcohol you have. For women, they say, 1 glass of wine or a shot, or I think it would be a beer. And for men, it's, they get 2, they get double of everything. So, but you'd really, it doesn't serve a purpose, so try to make that not part of your diet.
Perfect. All right. Now, the next question. Is there advice, Sean, I'm going to get to you with this one. Is there advice for how I should start talking to my friends, my family, my work, Like, what do I do with this new diagnosis? I don't even know all the details yet. How do I handle that?
I'm going to start with work first because I think that's where people have the most fear. We all have to work because we're not independently wealthy, and the first thing a person thinks about is, how am I going to do all of this? How am I going to keep a paycheck coming in? How am I going to keep my insurance? So after you have your treatment plan, I strongly suggest patients talk to their human resources department. There are federal protections, such as the Family Medical Leave Act, that guarantee you, if you have an employer of 25 people or more, up to 12 weeks of leave per calendar year. And that can even extend to your caregiver. So if your husband or your wife needs to take leave because you've had a significant surgery and then has to take you to your appointments, they can qualify for protected leave. You may also have private short-term disability benefits available through your employer that can help supplement your income if you don't have paid time off or you've run out of your vacation. So I would start with that. It becomes a little bit more challenging when we talk about sharing with our friends and family. Because if you're a normal human, you have different types of friends, those that you're closer with than others, and you have to prioritize what message you want to deliver. Also, some people are very private. They don't like sharing things. They're more introverted. So you really have to look at yourself and decide how much do you want to share with your immediate family and then with your friend network. I'm going to tell you, your family is going to want to know these things, and they're going to want honesty, especially if you have teenage children. They are extremely intuitive. Any parents out there will know that. They will know something's wrong. And it is better to include them in the conversation and explain things at their level than withholding it from them, thinking that you're saving them from a trauma. Now, obviously, your spouse or partner needs to be there with you and hear the information. As I was talking to someone this morning at breakfast, she said she only remembered about 50% of what the doctor said to her during her medical appointments. So having that partner with you to go to the appointments and be that backup ear to write things down, make sure you're remembering it, that you understand the instructions, that you understand what the doctor is saying to you, because we speak a different language, those of us in healthcare, and it can be, you may not understand what we're trying to explain to you. So, long story is, take it one step at a time. Don't feel like you need to run out into the world and announce your cancer diagnosis. Do it when you feel you're comfortable. But set a little timeline so that you're protecting yourself with work and that you're aligning your care partners to help you get through that journey.
Fabulous. All right. We're going to give you a little bit of that staging synopsis. Dr. Temple, will you take us through that?
Sure. So I think with staging, it's really important that you have that colonoscopy that's all the way through the entire colon, and it's typically reported out to the cecum. That you have a biopsy, I'm going to add to this, that we have a biopsy showing cancer, but also that you take the time to let the pathology do the work to tell us if this tumor is MSS stable or MS unstable, because that actually does impact the surgical decision making, and it will make a difference thinking through what our next steps are. So the next step is imaging. It's a chest, abdomen, and pelvis. It's a CT. We do, that's a fairly routine test, and that can be done relatively quickly, and it can be done at the same setting. And then the CEA, just a blood test that just is another marker for colon cancer. I think as we move forward in this next generation of better liquid biopsies, we'll probably move to something more, something else in the future, but for right now, we still use a CEA.
All right, so we're going to move on to our second scenario. We're going to change things up just a little bit. Now we're going to have a patient, 30 years old, who's just been diagnosed with rectal bleeding and has a rectal cancer. Dr. Hoffe, I'm going to start off with you. How is that staging and how is that process when you come in with a rectal cancer rather than a colon cancer, a different animal?
For us, the MRI scan, and I don't know if everyone in the room knows what an MRI scan is. I know a lot of patients sometimes have fear about an MRI scan, but it's an imaging test that after a patient is diagnosed gives us so much information about not only where the tumor is, but what possible lymph node involvement there is, and then some other features that all of us on the panel really help to make decisions. And it's funny because it's only probably been in the last 6 or 7 years in the States that the MRI scan has taken off. And the Europeans have done it for many years. And I will tell you, as a practitioner, we used to do something called an endorectal ultrasound, where the patient would go see their gastroenterologist. They would put a scope inside the rectum. They would bounce sound waves off the tumor, and they would get the depth. Because what everybody up here wants to know is, how deep is the tumor? Is it superficial, or does it penetrate through the layers of the bowel wall? And now we have so much more information based on MRI scan that the MRI scan, in addition to the CAT scans, tells us where the tumor is, where the lymph nodes are, and are there any sites of disease outside the pelvis.
Great. Dr. Christenson, what would you add to that in terms of that staging process and what you need to know? Because at this point, we're probably talking, and can you explain to us how radiation oncology and medical oncology may take a front seat rather than a early cancer?
Yeah, so the key distinction between rectal and colon cancer is location, location, location. In particular, rectal cancers are once the cancer is down in the pelvis as opposed to up in the abdomen. And one of the major reasons that this is important is that there's a lot of vital structures in that adjacent area that we would really like to keep right where they are, things like the bladder, the sphincter down at the bottom that allows us to go to the bathroom number 2 when we want to and not when we don't, the prostate, the vagina, the sacrum or the bone in the back. And so it's, as the surgeons would probably tell us, it's also a tougher spot to operate just because there's a lot less space to work with. And so we typically would kind of favor doing neoadjuvant treatment or treatment before surgery as opposed to surgery up front, as was mentioned as the standard of care in early stage colon cancer.
Great. And what's the process? I'm going to ask Dr. Temple, Dr. Hoffe, and Dr. Christenson, what's the process like? Can you tell us something, like people hear about this mysterious tumor board? Dr. Hoffe, you're shaking your head. Tell me, like, what happens there so you have somebody with a new diagnosis of rectal cancer, and I think this happens more with rectal cancer than it does with colon.
Yes.
What's this magical tumor board?
Yes, as someone who goes to 7 tumor boards a week, I can tell you a lot about tumor boards. At our cancer center, Moffitt in Tampa, we have a rectal tumor board. And the rectal tumor board is the best way for team communication. So one of us would present the patient's case, and then think of you're multiplying the specialists. There may be 30 specialists in the room or on the Zoom call. You have an expert pathologist who's looking at the patient's slides. You have an expert radiologist who's looking at the patient's imaging. And then you have experts in their field who are looking at the case. So really, it's amazing because you might get 30 opinions on what's best for the patient.
All about me.
Yes.
Wow. And so what kind of the decisions that come out of there? What are the choices of decisions? Dr. Temple?
So we actually just had our tumor board this morning at 7 in the morning, and I actually looked, and it's right. We had 8 surgeons on the call. We had 3 pathologists, two radiologists, I think 7 or 8 medical oncologists, and 2 rad oncs. So it really is this group. And I do agree, it's the best place to have communication because the doctors who have seen you are all there and all have different pieces that help pull the puzzle together and really help coordinate the care. And we really do talk about each patient individually, and we're really advocating for the right treatment. The question you asked was?
So where does it go? Like, who takes charge of my care? Like, who is my doctor?
So, you know, so I grew up in the area, so things have changed a lot in rectal cancer in the last 5-10 years, and I've always sort of said that our patients go to different doctors. They go to radiation oncology, medical oncology, and surgical oncologists. And nowadays, I always said I was the quarterback. And I would say you're going to go see the radiation oncologist, medical oncologist, they're your doctors. And then when it's time for us to think about surgery, you come back. And if you ever have a problem, I honestly think you could reach out to any of them, but I always had made it clear that sort of we were the quarterback. There's been a lot of changes in the way we treat rectal cancer. Only about half of the patients now who have rectal cancer need surgery. Certainly for the standard rectal cancers, about 40 to 50% of patients don't need surgery. So therefore, it really is in the hands of our medical and radiation oncologists to initiate initiate therapy and to get our patients through therapy. But we as surgeons are really integral in sharing the follow-up and making sure that we make these really important shared decisions about whether or not your next step should or shouldn't be surgery. And again, that also goes to the tumor board, and that is also a time when we all talk, the three modalities talk, to really think about what's best for you in this particular case.
And I'm going to put on my surgeon hat for just a second here, because one of my pet peeves is if you're diagnosed with a rectal cancer, you need to see a surgeon who treats rectal cancer before you start treatment.
Yes.
Because it can be really hard to figure out where that is if the treatment is started and then you go to see them. I'm going to change gears just a little bit. Jenna, I'm going to ask you about this next question, but particularly as a young patient with cancer, with colorectal cancer, what are the different things that, like, as a patient that were different than, you know, like if you're 55 or 75 or dealing with this?
Yes, so for a lot of young patients, it's, am I gonna have a family? Will I ever be able to have a family of my own? I'm so young, and my doctor has told me that because of my age, it's highly likely that it can come back multiple times. Will I be able, if I do have a family or young kids, am I gonna be able to, you know, be outside playing with them and doing all the things? Am I gonna be able to see my friends? All of those things come through your head, and it's just, you know, the way that the treatment makes you feel. A lot of times you just don't want to or can't, because sometimes you may not be able to get out of the bed for 3 days. You know, things like that kind of go through your head, but it's very, very important for you as a young, newly diagnosed patient to really make the decision. If you want to have a family, you have to plan for it at that moment. You don't really have time to think about it, because if you need to freeze your eggs or doing those things, you have to do it before treatment starts. And I think a lot of people don't really know, and they're like, oh, well, I'll just do a little treatment, and then after that, I'll look at the, you know, reproductive process, but a lot of times it's too late. So that's very important.
Yes.
And I think Jenna makes a really important point. These decisions actually need to be made before therapy. And I think it's a very very common sense for patients and for everybody that they want to get on treatment right away. Mm-hmm. You have time. You have time to get a second opinion. You have time to make these decisions. You don't have 6 months, but you have a month or two to make these decisions and make sure you're doing the right thing, because you're on this journey for a long time. And so it's really, really important that you take the time to make sure you've got your right team and to address things like fertility, because you're right, for women, if we don't address it up front, then a lot of options, there are still options, but there are some options that you've just taken off the table.
You know, and I'm going to come back to Jenna with one more kind of added question. I think that the time for those of us in the medical field feels very different from the time from those of us who are the patient or from the patient perspective. Like, how did you handle some of those delays and those times when we said, oh, we're going to get that right away for you, it'll be 2 weeks?
Yeah, so being young and diagnosed, I was in shock for a long time. I was probably in shock for about a year, maybe a year and a half, thinking that this was only temporary. This is just a small little nightmare I'm having, and my life will go back to normal. So for my experience, I really didn't have delays. When I tell you the doctors were like that with me, because they said that it was an anomaly. And I'm sure that some of you out there have a special circumstance where you're not like most of the other patients that some of the doctors are seeing on a daily basis. And so they didn't want to take any chances, because I had been misdiagnosed for over a year prior to that. I was already, you know, down the line. But I will say that the first question my oncologist asked me after he walked in the room and said, you have stage 4, I was like, oh. He said, well, what are your goals? What are your life goals? And I told him 2 things. And I said, I just want to see my son grow up, and I want to grow old with my husband. Those are the 2 things that mean the most to me. And 7.5 years later, when I walk in, those are the conversations we're having. So it's very...
I love that. Yeah. Dr. Christenson, before we leave the young early onset, are there other things that I need to advocate for as a patient if I'm going out and I'm a young patient, in terms of testing, in terms of things like that, as a young patient?
Yeah, so I mean, really at any age, but certainly in our younger patients, I think it's really important to understand. Sometimes there's not a really great explanation why some patients get colorectal cancer, but there are inherited reasons that can occur, and so particularly, if you have a family or something like that, it's very important if you can identify those causes because they do affect kind of the screening and the management of people's disease. So I think getting what we call germline testing, or basically testing for any kind of inherited changes that might predispose you to cancer, is pretty critical.
Great. Sean, I'm going to go to you with this question. What do I need to know about my sexual health? We talked a little bit about it, but what else would you add in terms of this for a young patient with rectal cancer, or any patient?
Well, this is a topic that's very important to me because my father was diagnosed with colorectal cancer at 29. My parents have been married for 1 year, and this was back in 1965, so the treatment options were not really developed, so he was very fortunate. But my mother has shared with me the struggles of being in this new relationship, being young, and having the changes to his physical appearance. And the mistake they made was they didn't talk about it. And I think being in your early 30s, we can all say we're at our prime, we feel like we look our best, we feel our best, our careers are taking off, and to have your physical anatomy change with an ostomy or with surgical scars can be devastating. So talking to a peer advocate, I refer a lot of my patients to Immerman Angels, where they can talk to someone who's been directly through it. If you are having challenges with your sexual performance, because we know some of the chemotherapies can cause vaginal dryness, delayed orgasm, impotence, bring this to your provider. What I've seen with a lot of patients is they don't think it's important enough to talk to their physician about. We should be talking about sexual health regardless of the patient's age, because we know that it's an important part of the human experience. Feeling desirable, physical touch, and they may be able to put you on medication to help you with those side effects, or put you in touch with a sexual therapist who can help you redefine what sexual intimacy looks like going forward with this disease.
I love that. I love that. I see a lot of nods. Anything else you guys recommend? Yeah, Dr. Hoffe.
Sometimes as a radiation oncologist, we are very proactive, and that is pelvic radiation can affect sexual health in both men and women. And so as Sean said, I make that a routine part of my consultation. I bring it up with every single patient. And for our male patients at my institution, I refer every single one of them to a GU doctor, a urologist, who will do some baseline measurements, kind of figure where they are out today. So if there's any changes, they might need a drug, they might need something to enhance their blood flow, that we start early, and so they know it's okay. Like Sean said, they know it's okay to bring it up. They know it's okay to talk about. And then we'll check at their follow-up intervals. Well, how's this going? How's that going? I guess it's like legitimizing, like Sean said, the right to talk about it.
Right, and I love the fact that you as a patient can also ask for these things that they're not necessarily offered. And it's something to feel like this is part of what I can do.
I think that we're learning more and more about the sexual implications of our therapy. Certainly, we know radiation has significant impacts, and so does surgery, both for men and women. And I think that it's also important for men and women to think about Jenna talked about banking, and we also, for men, banking before this, especially if it's part of their therapy is going to be surgery. You can get, you can lose the ability to ejaculate semen, and therefore it's harder to conceive. So if you've banked some sperm, it's also an important part of it. And I do think, even if we're not thinking about children, just preventing premature menopause and transposing those ovaries before we have radiation is also important. So it is really important to talk about fertility and sexual function as part of your preoperative decision making. And I think that we have a duty to talk about it, and hopefully if we get better talking about it, it becomes easier to talk about it with us. But I'm always very grateful when people share their struggles so that we can help find them therapy.
Yeah, and from
Yeah,
the patient perspective, with your partner, have open and honest conversations with your partner. If you need to say, hey, I need you to take more initiative to help for my lack thereof, then that's just what you have to do. If you have to schedule, okay, every Tuesday is the day, do what you need to do to just keep that relationship with your spouse as close as it can be. And you may not feel desirable as the patient, but also your partner may feel like they're not desirable if you are not engaging with them in the same way. So it's like a both and, caregiver and patient when it comes to that.
Thank you. Yeah, very important points. Dr. Christenson, maybe you can go through that staging, the rectal cancer staging before treatment, if you don't mind.
Yeah, absolutely. So much as was recommended for colon cancers, a colonoscopy going all the way to the cecum, so getting kind of visualization of that entire 6 feet of colon is critical with biopsy of that tumor. It was touched on very briefly, but there is a subset of rectal cancers with microsatellite instability, which is about 5 to 10%, which can be treated with immunotherapy rather than some of these other modalities, which can potentially save a lot of toxicity. Additionally, you want to understand exactly how far the tumor is spread so you can correctly sequence treatments, and that includes imaging of the chest, abdomen, and pelvis, blood tests with a CA, and we're kind of moving into doing more circulating tumor DNA as well. And then the MRI pelvis, as was mentioned, is really a critical part of rectal cancer staging, which is unique to it from colon cancer. And that's really to understand exactly how far it's invaded locally, both whether it has spread to lymph nodes, which can be important in determining how you sequence therapies and which therapies maybe you can avoid in certain circumstances, as well as understanding how far it's invaded into the wall of that colon or that rectum, and whether it's adherent to any additional structures that are important to know up front for surgical planning and also to plan the pre-surgical treatment. And as was mentioned before, really it's important that you see a surgeon before we start therapy. We have a multidisciplinary clinic at my institution, which I think is a really nice opportunity to see radiation oncology, surgery, and medical oncology, hopefully on a one-day visit. But I think meeting all the experts up front, I think, is really critical because they're all going to potentially play a very important role in really maximizing outcomes, and then discussion of those options at the tumor board.
Great. All right, we're going to move on to our third scenario. And this one is someone who's diagnosed with metastatic cancer. So a 65-year-old who comes in, not in the elective setting, not in the office, but rather through the emergency room. And on the scans, they're found to have metastatic disease. Dr. Christenson, I'm going to start off with you. What does that mean from a medical standpoint in terms of kind of where treatment's going to go? Let's just say the person doesn't have a blockage or an emergent thing going on, but how is this process going to proceed?
Yeah, so metastatic disease is really defined by that tumor moving outside of the localized region. So it can spread to lymph nodes, and that's typically stage 3. But once it gets beyond that, we do consider that metastatic disease and does make patients stage 4. In general, stage 4 disease is at least initially treated with systemic therapy. The thought is it's not necessarily just what we can see, but what might be lurking beneath the surface that we really need to treat aggressively with systemic treatment so we get it all up front. We certainly take every opportunity we can to treat patients with a curative paradigm or try to get rid of all the disease, but unfortunately, and this is why this kind of conference is so important, is we need to expand the number of patients that are cured, but in some instances, unfortunately with modern medicine, that's not possible, and so in those circumstances, we are treating with chemotherapy and other systemic treatments. Local treatments certainly have a role to try to extend life and to make treatment-related symptoms as little as possible. So good quality of life and as long quantity of life as we can make it.
Carl, I'm going to go to you on this. Because I'm going to be living now with this disease, and this is something that's going to be a longer term, are there additional thoughts that you have or ideas in terms of nutrition?
So it changes a bit for this patient because they're going to be going through systemic therapy, and that comes with side effects. So if you're lucky enough to have a dietitian at a cancer center that you're being treated at, work with them. A dietitian can kind of help with chatting to you and assessing you for any malnutrition. So say you've lost weight, poor appetite prior to this. And then they can provide suggestions or maybe even see if you would qualify for meals delivered to your home or shakes that might, help you get calories and protein, because calories and protein are vital for getting through your cancer treatment. They're going to help keep your muscle mass where it is, because that's what we want. We want a nice, healthy muscle mass. And they're going to help you recover from each cycle that you go through. Those would be kind of the main things that I would say, nutrition can kind of do, and the things that you want to focus on is managing side effects, and then also making sure you're getting enough calories and enough protein, mostly from good sources. But if you need to throw in some funny things too, that's okay. That's okay. It can all fit.
And Carly, I'm going to ask you another question. Is for somebody who's really struggling to keep the calories going in the middle of treatment, they've either lost their appetite or they have nausea, like what are some tricks and hacks that you recommend for them to be able to get something in?
Yeah. So going towards the foods that are going to be kind of more calorie dense. So if you are, one thing that I suggest to patients is fruits and veggies. We do want them in our diet. But if you get overwhelmed or you're not eating things quick enough, opt for frozen. Nothing wrong with frozen veg, frozen fruit. But you can use frozen fruit all year round. It's picked and flash frozen at the peak of ripeness. And you can make that into smoothies, because sometimes liquid calories are a good way to get in calories. So you can use your frozen berries, you can freeze bananas, you can freeze grapes, you can throw anything in a smoothie. Then you can load in peanut butter, almond butter, sun butter, any butter. Or maybe coconut milk, and then you could throw some protein powder, or maybe you don't like protein powder, so you use cottage cheese or Greek yogurt, or even silken tofu to kind of make a shake that you could sip on and help you get some calories and protein. I also think working with the team or a dietitian to kind of see what is maybe the hang up with the eating. What is the culprit here? Is it nausea? Because sometimes people really can't identify that. Is it that you're gassy? Because there are some solutions for that. Or is it taste? Because a lot of people will find going through treatment, they just lose their taste for any animal sources, except for dairy. And so then it's kind of, let's opt for some beans, some lentils, some tofu, edamame. Let's play with some protein powders. And what can we sneak Greek yogurt and cottage cheese into? And sometimes eggs are still viable. People will eat some eggs. So it's just kind of being crafty and finding ways around some of these taste changes or nausea, and loading up calories early in the day. Mm-hmm. And then there's always Ensure Boost, OWYN, own shakes that we can add more calories to. I think all those things taste better when you put ice cream in them. And that's a quick fix.
Jenna, I see a lot of head nodding. I think you have something to add there.
I do, because as Carly was talking, I'm just thinking back on the things that I had to experience. And my nutritionist and my social worker at the hospital are very close to me. We're very close. We talk all the time. And when I was at one of my very, very low points, I had my nutritionist on speed dial. I went 2 weeks. I couldn't eat for 2 weeks, and my husband was trying to put everything in shakes to try to feed to me. And then I was vomiting. Every time I would drink a shake, I would vomit, so I stopped. But then she said, no, you drink 2 ounces at a time every 2 hours. And that helped. So that relationship with my nutritionist, it just helped me along the way, because you don't know what you don't know. So it's very important that you just try to do everything you can, because the one thing that I try to stay away from now is not eating, because once you stop eating, that is a decline, and it's not a decline that any of us want to go down, and that's like sign number one. So do whatever you can. My husband would force feed me. I told him, hey, you got to force it. Like, if I say no, you have to force it. I told my mom, everyone, just get me to eat. I lost 20 pounds, if you could imagine, and it just was not good. So that relationship with the resources at your hospital are key.
And I love, and I just want to point out, one of the things that you said is really making sure that you get those people on your team, right? That the people, your nutritionist, your social worker, are there to help.
Yes.
Yeah.
Can I add something? So Jenna said a really, really valuable point. That kind of every 2 hours, I say like 2 hours would be awesome. 3 to 4 if you can get it in, but that's if you're a caregiver or if you are the patient, to kind of make sure you're not going longer than that 3 or 4 hours. Something little, just like think of little kids or toddlers. Like, you would never dare leave the house without a snack. So you should be eating that too. And if you don't have access to a dietitian, the Leukemia Lymphoma Society does have, they offer for any cancer type, 30-minute consultation with a dietitian, lls.org. So I just wanted to put that in there because that's an awesome resource for people that don't have access to one.
I love that. Sean, can we switch over a little bit to maybe kind of more of the mental and the, like, how do I keep myself strong? How do I get resources to get through this, to persevere?
So I could speak for 2 hours on that, but I know I've got 2 minutes. So starting.
Take 3.
So,
I'm feeling generous.
And I think this is an area we don't get enough attention to, is that immediately after being diagnosed, and a social worker I worked with for a long time, she had a great analogy. She's like, that patient is in a boat on a lake in a fog. They can't see the other side, they don't know what direction they're going, and they don't know where to paddle. So giving yourself the grace to not know. The other thing I always tell people is appreciate the well wishes, but recognize positive toxicity. Mm-hmm. We always hear that you need to stay positive. It'll cause, if you're negative, it'll cause the cancer to grow. I've heard that 4 million times. A positive attitude will help you with all these things. A positive attitude can help you with quality of life, but denying the feelings that you are having, the fear, the anger, the bargaining with your higher power, the why, that's not going to help you. You need to experience all of those emotions and work through that. And working through it looks different for every different person. It could be meditation, it could be taking long walks, it could be praying, it could be talking to a social worker, or it could be talking to a peer advisor, somebody that has been through it. So I always tell people, every emotion is a good emotion. Allow yourself to feel it, because if you suppress it now, it's going to come back 10 years from now, and evidence itself is another problem. When we begin to think about, and the other thing I'm big about is when you're feeling sad right after a diagnosis, that is not depression. And I hate it when I would get a consult and say, you need to go in and see this patient. She's crying, she's depressed. I'm like, no, she's not depressed. She just got told the worst news of her life. Mm-hmm. She is having a normal reaction to life-threatening news. So I stay away from that. We talk about sadness. If your sadness goes on for about 6 months and it's interfering with you going to work, with your relationships, with intimacy, then we begin looking at, is this a true depression, and do we need to start managing that with medication and talk therapy. I also recommend people get into a support group. And as you heard this morning, someone talked about a support group it was a bunch of negative people. Support groups, they come in all different varieties. You need to find your niche. That group of people that listens to you, validates you, can give you some ideas on how they've coped with their diagnosis, and use that as your team when you're having a bad day. And I know that with some support groups now, they have an app where you can connect with all of the support crew members at any time. So like at Moffitt, we have a metastatic breast cancer support group, and all of the women are on this group. And if they're having a bad time at 2 o'clock in the morning, they can get on there, and there's somebody that's awake that can offer a piece of advice or validate them or say, I'm just here to listen to you.
I love that. Thank you. Jenna, what else would you recommend for people to keep themselves emotionally and their souls healthy as they're going through this?
I would recommend you finding what grounds you. So me, I journal. I've chronicled my journey since day one back in 2017. And I think the guy who did the book yesterday, Paul, I think he said the same thing. I've been writing letters to my son every year of his birth. And that kind of helps me. And I think it's something that will help him as he gets older to just kind of understand. But you want to find your tribe, because I started group therapy after 2 years in, and I was at my complete bottom. I didn't know where else to go, and so I knew that that was the time for me to seek help. But had I known, or someone told me, get help before you get to that period, I think it would have been a little better. So those groups are for community, and it's not just for other people to help you, but it's for you and your experience to help others, because you really don't know what someone else is going through. And if you have experienced something and they just haven't voiced it, you have helped someone. So it's really important to think about your mental health, because your mental health makes you a better spouse, a better parent, a better friend, everything better. And it keeps you motivated, because I like to tell everyone, your mind will believe anything you tell it. So if you're feeding your mind negativity, that's where you're gonna go. If you feed your mind positivity, that's where you're gonna go. So I leave it at that.
That's great. Let's talk about the role of goals. Sometimes I think when you get this type of diagnosis, it feels like I don't have control. How do the goals play into like my treatment modules? How can I make that part of my journey? Dr. Christenson, maybe I'll start off with you. Like, when they talk to you and they come in with goals for like, this is like what I'm willing to do, what I'm not willing to do, how does that play into how you talk to your patients?
Yeah, I mean, I think it's very important to have an open conversation about what's important to you in your treatment, because there are, as you mentioned, there are some things that patients really want to avoid. As was mentioned, sometimes very aggressive treatment up front may be able to, get rid of the tumor without surgery. And so if that's an important goal for patients, then sometimes they're willing to take a little bit more upfront toxicity for the hope of achieving that goal. Alternatively, other patients that may not matter as much, they might be more worried about the chemotherapy or the radiation, and so you can kind of adjust the treatment plan based on what's important to the patient, while also keeping in mind, what is going to maximize their chances of cure. And so we try to be very open and honest about kind of the statistics involved with it as well. But I do think it's very important that you articulate, and I think throughout the course of treatment, your goals and what's important to you also may shift. And so I think maintaining that conversation throughout the course of treatment is also very critical.
Dr. Hoffe, I see a lot of nodding. Do you have something to add to that one?
And I thank you, Dr. Stein. Just advocating for yourself. I think Dr. Temple mentioned this earlier, not feeling rushed. So often patients come in and they feel rushed to make a decision. And so maybe you're sitting in a doctor's office, and as Dr. Christenson said, you don't know if you want to go to surgery or not. You haven't had enough time to process it. And so don't be afraid to say to the physician, you know what, I'm not ready to make a decision today. I appreciate this information, but I want to follow up in 2 weeks where I can talk to my family and then come back. It's like allowing yourself the time to make the right decision for yourself.
Dr. Temple, I'm going to bounce over to you. Anything to add to that?
No, I think everything we've talked about is really valid. I think it's very important that we understand goals, and especially as we move into that metastatic setting. As physicians, we just keep looking at ways in our toolkits to put people through different therapies to potentially render disease-free. And we know that doesn't always work, and so it's really important that we understand goals. I always think it's quality and quantity, and I sort of frame it in that context, and really thinking about optimizing quality. And if we get quantity, we get that as well. And different goals change at different times, right? And I think we need to really understand what our patients' goals are, because we see people in such a short period of time in such a false artificial way, and so we don't know necessarily what's happening outside, and so it really behooves us to ask, and you're not wasting time by telling us these things, because it really helps us understanding the stories, really helps us understand why these goals matter to patients and in the way they do.
And if I could add really quickly, it's also important that the patient communicates those goals to their family members and creates an advanced directive. Advanced directive has two parts. One is the healthcare proxy, which that is the person that can make decisions for you in the event you can't speak for yourself. And then the second part is the goals of care. And you can spell out, you can be as specific as you want to be in the goals of care. And from the healthcare provider, when somebody comes in with that and they've had a conversation with their provider and they've made the goals clear and then documented that, it makes our job so much easier, because we know we are giving you what you want to have. So.
Jenna, were you?
Well, I would just say, hindsight is 20/20, and had I known a lot of the things I know now, back when I got diagnosed, I would have asked more questions to know what I was getting myself into. Now, do I think it was the right path? Yes, but I had no idea what was going to happen to me. Side effects just kind of came out of the woodworks. So if you are newly diagnosed, it's good. Like, this is the setting, this is the time to communicate and fellowship with those who have been doing this for years. My first AllyCon, I met someone who was 40 years out, and I was like, oh, that's the hope I needed. So this is the time to build community with those who are on similar paths that you are on. And for me, for my goals, our roles have reversed in my doctor's appointments. My doctor is the one with the pen and paper, because I'm like, this is what I'm not gonna do, this is what I liked. These are the things that have worked for me, so you should tell other patients. And the more you speak up about your preferences, because it's your life, it's your body, like, you are the decision maker in that doctor's office. Whether you feel like it or not, you are. So just go in knowing exactly what you want to do and what you cannot tolerate, and talk to your doctor about everything. So, yeah.
Thank you. We're going to close with a few slides here. I'm going to start off with this one. I'm going to give Jenna, I'm going to have you kind of talk about from the patient perspective. Yeah.
Oh, yes. So seeking help for a mental check-in, it's so needed. Like I said before, journaling and finding that thing that keeps you grounded is good, but if you feel like that's not working and that you kind of need someone to get your mind thinking in a different way, or a support group, all that's good. However, use the resources that you have available now, and then seek additional resources that might take a little more time, like finding a doctor to talk to, like a psychologist. Those might take time to get into an appointment. And then it also takes time for them to get to know you. It's session after session after session until they can really kind of dig into the help that you need. So it's very important, because, like I said, having your mental equilibrium set is good for you just as a person, and it makes you feel a lot better. I guarantee you it will. Let me just keep going, because
I know you've covered some of them. Do you have anything else to add about the other two?
Yes, I did cover that. I did. I talk a lot, y'all. So I guess I gave you everything that I had to give, but I feel like there's just so much that I could say, and we only have like 3.5 minutes, and I don't want to take up everything. But after this, I'm available for anyone who wants to talk. I'll just leave it.
Thank you. All right, so we will go to nutrition.
Okay. So give yourself time to recover. That's from each cycle, and that is from your treatment in general. Like, it took a long time treatment. It's gonna take time to recover. Your side effects won't stop the day the treatment stops. So give yourself grace. The other thing is look for evidence-based resources, American Cancer Society, American Institute of Cancer Research, because there's so much out there and it's so confusing. And if you're confused, ask. Ask someone that you trust, like an expert. And And all foods can fit when it comes to a cancer-fighting diet. I'm not really about taking foods away. And I think if you're looking at any resources that are too extreme, that's a red flag. So certainly all foods can fit. If you hate vegetables, could we consider some herbs and spices? Because that's cancer fighting. Garlic and onions count too.
Fabulous. Sean, will you talk to us a little bit about sexual health and just kind of give us an overview here?
Yeah, and like I said earlier, it's, this is the topic that not everybody gets to see a Dr. Hoffe who makes sure to bring that into the conversation and recognize it. And what I would leave you with is, this is an important part of your life. We all enjoy physical intimacy. You have the right to go through your cancer treatment and still have sex if that's something that you want to do. Still experience that physical intimacy. Go to your provider, talk to them about the problems you're having. Be honest with your partner. And so sex can look different than what it did before. It could be intimacy, it could be toys, it could be lubricants, it could be things that taste. Kind of open your mind to exploring different parts of your sexual side as you go through this. You have permission to do that from everybody up here on the stage.
Fabulous.
Good way to end.
We got some applause there. Well, I think that is going to wrap it up for us. What I want you all to do is to thank this fabulous panel and everything.
Thank you.